Hello, everyone, and welcome to our third National Neonatal POCUS Collaborative webinar. We're going to give people a few minutes to join. Still have some people in the waiting room. Right, I'm going to go ahead and start. So hello, everyone, and welcome to our third National Neonatal POCUS Collaborative webinar. The chat function is disabled, so please use the Q&A feature to post questions. We will answer those during the Q&A session. This webinar is being recorded and will be uploaded to the collaborative website, which is newpocuscollab.com. Our guest speakers today are Dr. Tom Pawlowski and Dr. Will Corder. Dr. Tom Pawlowski is a neonatologist and assistant professor of clinical pediatrics at the University of Pennsylvania School of Medicine. He practices at the Children's Hospital of Philadelphia and Pennsylvania Hospital, an in-network level 3 NICU, at which he is establishing a point-of-care ultrasound program. And during his fellowship training, Tom developed a special interest in using point-of-care ultrasound to evaluate ECMO cannula positioning, and is now actively involved in teaching the skill to neonatology fellows and bedside clinicians. Dr. Will Corder is an assistant professor of clinical pediatrics at the Children's Hospital of Philadelphia. Will's expertise lies in the application and teaching of diagnostic and procedural point-of-care ultrasound in a wide range of neonatal patients and pathologies. Having trained at a high-volume medical and surgical ECMO center, Will has developed Will has helped advance the imaging options for both VV and VA ECMO cannulas using bedside ultrasound.
All right. Hey, Tom.
Hello, Will. Thank you so much, Dr. Kitab. I can speak for both Will and I that we're both very thankful for the invitation to discuss this important topic today, and we're excited to share it with you all. So without further ado, let's talk about point-of-care ultrasound for VV and VA ECMO cannulas. Next. We have no financial disclosures. Next. And really, we're going to split this talk up into two parts and ultimately aligning with two objectives. The first part I'm going to talk about is we're going to talk about how POCUS can improve our current standards for assessing ECMO cannula, especially compared to traditional methods. And then we'll transition to Will, and he'll talk about using a practical approach to image POCUS cannulas and ECMO cannulas using POCUS, and show you some more practical guidelines and steps for that. Next. So I know this group is very familiar with ECMO, but just to start off and review some basic anatomy and review ECMO cannula positioning, so we're all starting from the same point. This is a diagram showing VA ECMO, and what it shows is a venous cannula inserted through the right internal jugular vein and terminating in the right atrium, and an arterial cannula inserted through the right common carotid artery and terminating at the insertion of the aortic arch. And we all kind of know where the correct positioning is supposed to be, but unfortunately, it's really difficult for our surgical colleagues to find an exact position for that. We currently use external measurements or weight-based estimations, and so they're limited by kind of those estimations, and it would benefit from more dynamic image guidance. Next. Excellent. So we'll focus on VA ECMO cannulas on this talk, but there's a lot of different other cannulas out there that I just want to touch base on, specifically VV ECMO cannulas. And so these are two that we use at CHOP, the Crescent jugular double lumen catheter, that's the image to the left. And then we used previously an Avalon Elite bicaval double lumen catheter, but we've transitioned more to the Crescent. Just wanted to show these two because they also have specific positioning to optimize flow. The Crescent on the left, you would want that cannula terminating in the right atrium, and it has an outflow jet that you want angled towards the tricuspid valve. And then the Avalon is unique in that you want the cannula passing through the right atrium with the distal port ending and terminating in the IVC. Next. So ECMO cannula positioning is essential for venous drainage and optimal flow. And it's really, really challenging in our patient population. I'm sure we've all experienced that at the bedside, specifically due to their tiny cardiac dimensions. If you think how small their heart is, there's not a lot of leeway. And then on top of that, some of our patients, such as congenital diaphragmatic hernia patients, have altered anatomy with a shifted mediastinum, making malposition easy. And complications can occur, such as atrial perforation with cardiac tamponade, arrhythmia, or frequent circuit cutout, which I'm sure we're all familiar with and struggle with. And the incidence of cannula complications is not trivial. And in fact, the most recent ELSO data suggested that, or reported that complications associated with neonatal ECMO cannula in the respiratory ECMO cases was about 12%. On the right side of the screen, you'll see what a typical image of an X-ray showing appropriate ECMO cannula placement with a venous cannula position in the mid-right atrium and the arterial cannula in the right common carotid artery extending into the aortic arch. Next. And traditionally, we use X-ray to confirm ECMO cannula positioning after placement or for routine surveillance. But it's really limited by the obscuring of traditional landmarks, and it's been shown not to be sensitive for cannula malposition. So on the right here is an example of this. We have a patient who is a CDH patient on VA ECMO with the venous cannula tip denoted by that white arrow. And who knows where that is terminating, right? The whiting out of the lungs, the shift of mediastinum make it really difficult to determine where the correct positioning is. And we've tried different things at our institution. We've had echocardiography come and help, and they've seen the cannula tip about 75% of the time, but they're also limited by windows and also by the availability of echocardiographers. Next. And so this concept that echo could be helpful for X-ray is not a novel idea. Years ago, there's been data published comparing X-ray with echocardiography and showing that echo is superior to X-ray. So in the study on the left, next, Will. This Thomas et al. Performed a retrospective review of 91 ECMO patients who had echocardiograms and chest X-rays. And the majority of these patients were VA ECMO patients. An echocardiogram was obtained to check cannula placement in 33 patients. And of these patients, 4 required repositioning due to malpositioning, for repositioning due to the venous catheter malposition. And then the other 58 children, echoes were done for other reasons and actually found malposition in 4 other cannulas requiring readjustment. And in those cases, chest X-ray failed to identify suboptimal positions. So Will, can you hit next, please? In another study, in another study on the right, Kensler et al. Compared their standard ECMO cannula technique versus ultrasound-guided positioning, and they found a significant reduction in surgical repositioning from about 18% in the non-ultrasound-assisted group to 3% in the ultrasound-assisted group. Next. And so we know that XLA alone is insufficient to assess cannula position. We know that echo is an improvement to that. And so our group, led by Maki or Dr. Fraga, leveraged their expertise in point of care ultrasound to start evaluating ECMO venous cannula position in our neonatal population, and we published our experience a couple of years ago. It was a single center retrospective review of our babies on ECMO with studies between 2017 and 2019. And the POCUS study was reviewed and for successful identification of the cannula position, and then compared with X-ray and echo, and for agreement using a kappa statistic. Next. POCUS was was successfully able to identify the venous cannula tip in 90% of the time. Click. 3 of the unsuccessful studies were performed on CDH patients with a significant meniscus shift and a venous cannula that was unable to be advanced during cannulation. And POCUS could not identify the cannula tip, presumably due to the poor acoustic windows, lung artifact. Next. A malpositioned cannula was identified 50% of the time, with most being deep. And of those 23 malpositioned cannula, an intervention was performed in roughly half of them. 8 patients had the cannula pulled back, 3 of which were under POCUS guidance, and 2 patients had a non-surgical repositioning, and 2 patients had a second drain placed. Next. All 46 patients had successful POCUS study and X-rays available for comparison. The median time in between studies was about 5 hours and 5.5 hours. And there was 43% discord between the 2 modalities and a kappa statistic of 0.13, showing only slight agreement between the 2 modalities. Next. In 19 patients with cannula in position on the X-ray, POCUS identified malpositioned cannula, with a positive predictive value being only 54% for X-ray. Next. And there was 1 patient in which X-ray found the cannula to be malpositioned, but POCUS identified correct positioning. Next. And of the 51 POCUS studies, only 18 had corresponding echoes, and 6 additional studies were excluded because either the echo or the POCUS couldn't see the venous cannula tip. But of the successful studies, there was about 90% agreement between the 2, with kappa statistic of 0.78 showing substantial agreement. Click. 2 patients had echoes that found the cannula to be in position, while POCUS had found it to be in malposition. Next. So really, when we think about our study, we really showed that and confirmed the ability of point of care ultrasound to identify ECMO venous cannula position. You'll note that we specifically looked at the venous cannula positioning as opposed to combining with arterial cannula. But we found and confirmed that ultrasound itself is superior to X-ray for that identification of a malpositioned cannula, very consistent with prior studies comparing with echo. And it showed that we as neonatologists and those learning point of care ultrasound can gain the skills and develop the expertise to be able to assess it in a real-time manner with a specific clinical yes/no question to hopefully improve the care of our patients on ECMO. Next. So when do we use it? There are a couple of different indications we use it in our unit. The first is really kind of routine cannula positioning and screening. So if we see an X-ray that shows slight malposition or concern for positioning of the cannula, we'll use ultrasound to corroborate the findings. The second is if there's a period of clinical instability or circuit instability where you worry about cannula malposition. So if there's frequent circuit cutout, you're giving a lot of fluid to keep the circuit running. If there's an arrhythmia like SVT that you're worried about it abutting the atrial wall, or if you are worried about a tamponade physiology on your other kind of monitoring and you want to evaluate for pericardial effusion or something like that. So that's kind of your like crash course, immediate, let's assess and make sure that the patient and the circuit are safe. And then the final part that we've had some success with and it's been fun doing is doing real-time image guiding during ECMO cannulation and having a dynamic conversation with the surgeon at the time of ECMO cannula placement. And we've had some success to find those and put them in the best position possible. So as we've talked about these, I want to just harp on one kind of point that and reiterate that like much of point of care ultrasound, the use of ultrasound for this indication is really a yes/no question as indicated by these different ways we use it. And the yes/no clinical question is there something I can do in real time to make the patient better? This is not meant to be a formal echocardiogram. It's not meant to look for congenital heart disease. And it's not meant to formally replace our cardiology colleagues. It's meant to be an adjunct and actually ease the burden of our colleagues so that we're not calling them at 3 a.m. For an emergent echo. And so with that, that's kind of the first part of this talk to introduce you to the subject, give you the reason why we're interested in it. And at this point, I'll hand it over to Dr. Corder to kind of go through the practical hands-on part. Thanks, Will.
Yeah, thanks, Tom. Why don't I just briefly check in with the moderators, make sure that we have any questions answered, and then we'll move into the imaging piece. This is a great range of indications, Tom. I think, with increasing levels of stress, you have, one that begins with surveillance, routine surveillance, one that begins with, clinical problems at the bedside, and then finally one where you're doing it right next to a surgeon. So, we'll talk a little bit about how to sort of gain these skills so that you can tackle these questions in real time as stress increases. So I'll keep moving on. Feel free to stop me, moderators, if there's any questions that come up. So, it's a little bit interesting in how we approach this, and I think it's really sort of spontaneously driven just by trying things at the bedside. The natural, probe that people reach for is the cardiac probe, the phase array probe, and that comes out of a long history of echocardiography and looking at these structures, and then I'm going to show you some images actually of using a different probe, the long linear probe, and these can really give us particularly wonderful surveillance pictures, of the ECMO cannulas, and I'll sort of make a case for both the utility of both probes in use. There are several views that we're going to talk about without ECMO cannulas in the image, and just to sort of orient ourselves, and then I'm going to sort of give use scenarios for all of these views, or two of the three SVC views. There's three standard SVC views that can be used in echocardiography. One is a suprasternal view, very high up. The second is a right parasternal view, a little bit lower down in the chest. And then the third is a subcostal bicable view. It's a view in a longitudinal orientation in the subxiphoid region. All three have the ability to see, the ECMO cannula coming in the SVC. And then the aortic arch view really is what's used to see the arterial cannula coming into the common carotid and the ascending aorta. A few considerations when you're trying to get the best images possible. The first is, that you really want to see as much of the cannula as you can, and you want to see all the way down to the cannula tip. It's similar to imaging UVCs or PICC lines. It's one thing to sort of see the cannula itself running, but really to say where it terminates is of great value, clinically. And then the second is, you really want to see as much of the right atrium as possible, particularly in these cannulas that either are supposed to terminate in the right atrium or pass through the right atrium and stop in the IVC. And so that really is going to throw out this first view, the suprasternal view, and I'll show you why. But the suprasternal view classically doesn't have a ton of the right atrium included in the image, and so we sort of start to look for other images to really, ideally capture the ECMO cannula coming into the right atrium. And then the final one is that, particularly in VV ECMO, but VA ECMO as well, the venous side of the cannula, we really want to see the tricuspid valve There are a few use cases in that. The first is, we want to make sure that the cannula is not actually going through the tricuspid valve into the right ventricle. And then the second really is that, the outflow jets of a VV ECMO cannula should be oriented correctly over the tricuspid valve towards the right ventricle. And we can actually look at the jet streams on ECMO, which is incredibly valuable when you compare that to radiography. So the rest of the talk really is just looking at images. So I have the easy task of teaching you how to do this over Microsoft Teams, and I hope that these transmit. I will say just right off the bat, this takes a lot of practice, and there's a lot of members, of the collaborative and people who have done this long before, I've started doing this, that are more than willing and able to jump in and help you learn these skills. And so, some of these things, this is really just to whet your palate and get you started. But, some of these things really just take time and energy at the bedside, particularly as you have these ECMO runs, really getting into the, getting to the bedside on a regular basis. So we're going to go through the three views. This is the suprasternal view, and what you can see here, the head is oriented. I've got a little marker here. Let me see if I can raise laser pointer. The head is oriented to the right of this image. First, let me go to the baby and then the probe. So the probe is really oriented to about 12 o'clock in the high suprasternal region. You can see the indicator here pointing up towards the baby's head. You do want to remember the orientation of the great vessel. So, as going from the baby's left side to the right side, you're going to see the great vessels in orientation go from the pulmonary artery or the pulmonary trunk to the aortic arch and aortic trunk, and then the SVC coming into the RA. So you really want to get in the habit of processing that orientation. If you see yourself over the aortic arch, you need to get a little bit out further to the baby's right side. If you see the pulmonary trunk, you've got a good ways to go to get to the right side and see the SVC into the RA. So the SVC sort of looks like a large vessel coming in from the head side of the image. And then you sort of see that the right atrium here, a continuation of the SVC, it isn't well imaged in this picture. We do have some lung artifacts occurring here, but this isn't going to be the best situation to observe a cannula coming into the right atrium and really trying to figure out where an ECMO cannula terminates. And so I will sort of let you know that this is something you'll read about, but not a view that we necessarily reach for all the time when looking for ECMO cannulas in particular. The right peristernal view is a fantastic view for ECMO cannulas. And so this is a little bit different. So you see now we sort of have come down the chest. It's not as high of a view on the chest. And you can almost imagine if this infant had an ECMO cannula in the right neck region, you can almost imagine the orientation of this probe being from cannula in the right neck down towards the IVC. And that's really what the image is going to show you here. So we've shifted down now. We see less of the SVC coming in, a little bit there on the right side of the image towards the head. We see the RA in a much better, cross section here. We see the IVC down here terminating with a little bit of the eustachian valve. And then just to point out a few other things, I didn't label them here. I labeled them in further slides, but this is actually the tricuspid valve right here. RA into RV always being the most anterior structure on the image. So this is a fantastic view for ECMO cannulas, especially in the, those use scenarios where you're looking to surveil ECMO cannulas, you're looking to troubleshoot cutting out or all those things that Tom mentioned. But you can imagine this may not be the best view when you're working with a surgeon who has a sterile field. So that brings us to the third view, which is the bicable subcostal longitudinal view. You're going to see a few different ways that this is imaged in echocardiography textbooks, and I've classically started to use the image that's been taught in targeted neonatal echoes. And this is a flipped image now. So we've, inverted the image, and the probe marker. So the probe itself comes down into the subcostal region where you classically scan the IVC. You start to tilt drop your hand and tilt up towards the heart here, just so you can really start to get up into the heart structures and then up into the SVC. And the orientation of the probe marker, this is a little bit strange, is down towards the baby's left foot. And so, I cut it off here, but the probe the indicator of the probe marker is right here. And so all of this side, the right side of this image, is down towards the feet, and all of the left side of this image is up towards the head. This is a fantastic view of you that we've really been working on for some time now, because it adds the best value in terms of working with surgeons. You really bring the probe down out of the field, and you can imagine the surgeons having a nice sterile field while you're working under a drape here to watch the cannula in real time. You'll have to humor me a little bit. So this is SVC sort of coming in here into the right atrium, and then the IVC here. So you can imagine a cannula, if this, we'll show images of this, but a cannula coming into the SVC, and if it's supposed to terminate in the right atrium, this is the target here. And then again, we have the tricuspid valve here opening up. Again, this is now anterior, the bottom part of the image, because we inverted the image. So the tricuspid valve opening up into the RV. This is just an example of the aortic arch view. Truthfully, it can really be difficult in VA ECMO to image the aortic cannula, or sorry, the arterial cannula in the aortic arch, particularly if it's a high or just a touch high. If it's really deep, it can be a little easier to see, and that adds value certainly. We're really looking for misplaced or malpositioned lines. So the first thing I want to point you to here, let me see if I can get this to play in real time. So this is the aortic arch view. It's a high suprasternal view, really similar to that suprasternal SVC view, but a little bit more to the baby's left side now. And you see the arch coming in, moving towards the head on the right side of the image, coming in and then wrapping down towards the posterior aspect of the infant. And then what you see here coming into plane is these two little white tram tracks are the arterial cannula coming in to the common carotid right here. So a nice shot of this. You can see how it's maybe a little difficult to see. This is a well-positioned cannula. Common carotid, cannula there, as shown by the red marker. And then on this side, if you apply color Doppler, and I'm going to show some images of color Doppler, in a few slides as well, you can really see the outflow stream. So this is a blue stream of blood coming out of the arterial cannula. Blue is moving away from the probe, and so this is going down the aortic arch trunk, the transverse arch, and down into the descending arch. Cannula tip there. Now, moving into some of these, so these have all been phased array probes, and I'm going to show you linear probes in a moment. But with these phased array probes, I've given you 3 examples of where you could potentially scan the SVC. I have now intentionally taken off the labels of these images because, unfortunately, when you're using an ultrasound, a point-of-care ultrasound at the bedside, it doesn't come with labels. So I want you to get in the habit of seeing these in real time. This is a great picture of a venous cannula. This, if you can imagine reaching back, this is in the right peristernal, image. So you've got predominantly right atrium. You've got the head over here on the right side. The SVC comes in to the right atrium from the right side, and then the IVC we don't really see here in cross section, but you can see this really nice, cross section of the cannula, and you have a decent idea of where the tip might be here in the right atrium. You can even see some of the outflow ports here, or little small details of the cannula. It's really fascinating to see in real time. So there's the cannula. This is the right peristernal. For those who are a little bit more familiar with echocardiography, this is almost like an RV inflow tract view in the peristernal long axis, right? You've got right atrium, tricuspid valve into your right ventricle anteriorly. SVC, tricuspid valve, all the things we talked about. I lied. So the last one had labels. This one will not. So no more labels. We're done with labels. So this is a similar image. You know, whoever did this one really likes gain, and so we really, you know, covered this one in snow, but you get the same detail, right? So this is a right parasternal image. This is the cavity of the right atrium here. This is the SVC coming in here, and this is actually the IVC down here. And then this is the cannula right here in the right atrium. The tip of the cannula really is down here, you know, sort of oriented towards the IVC. You can see the tricuspid valve opening up here. You don't have a great shot of the right ventricle, but the tricuspid valve is nicely opening in that shot. And this is a well-positioned cannula, maybe, you know, getting a little close to that IVC region deep in the RA. But, you know, as time goes with this infant, if this infant were to develop any sort of swelling or edema through their ECMO run, this, you know, this cannula is likely to shift back a touch. And so well-positioned cannula placement. Here's another variation of that, so same shot. This is in an infant who had a small pericardial effusion and also a pleural effusion, but you can see sort of similar orientation, okay? Just want to get used to this, you know, SVC coming in from the right side, IVC down here on the left, the chamber of the right atrium, and then the tricuspid valve opening up into the anterior-most chamber, which is the right ventricle. You know, you can see this is a little bit different than the others. Sometimes, you know, they don't always look the exact same, but you get immense value just seeing this beautiful shot of the cannula coming here into the right atrium. And you know, it's not abutting the wall. It looks, you know, like it's sort of freely floating in the chamber of the right atrium. So well-positioned cannula. Again, in the right parasternal view. So this is sort of mid-chest. And then this is with color Doppler applied. This is really fascinating. So this is a veno-venous ECMO cannula. So we have an inflow port coming in from the tip of the cannula. That's this blue jet. So blue, again, is blood flowing away from the probe. So this is blood flowing away from the RV, away from the tricuspid valve, back into the venous cannula. And then red here is the outflow port of the veno-venous ECMO cannula. And that's really, you sort of see that crossing the tricuspid valve, well-oriented, moving through the tricuspid valve towards the RV. So really fascinating sort of circle of blood here happening in real time, inflow and outflow ports of the veno-venous ECMO cannula. And then we're going to jump into some large linear probe images here, and then we'll finish with some cases. And I do hope to have a little bit of time at the end. We have a fantastic panel of you know, experts and people who have been wonderful mentors to me to, you know, really answer your questions. But so large linear probe. This has been a really fun sort of probe to view these ECMO cannulas. It's particularly good in the right parasternal region. The images that I just showed you, it's going to sort of replicate those images in a large way. It's you know, something that we reach for, particularly when we're doing surveillance, you know, sort of daily or you know, cutting out questions, surveillance scanning of the ECMO cannulas in our unit. It's got a wider footprint, it's got increased resolution, and it's you know, it adds, I think, a different dynamic than echocardiography does in seeing these things. The limitations really of the linear, you know, the linear probe really are related to its, you know, sort of physics underlying. So, you know, if you've got, you know, a situation where you're not collapsing the lungs in an ECMO run and you've got an open lung strategy, it can really be difficult with the linear probe to see these structures. And then, you know, the bony structures of the chest can also lead to some posterior acoustic shadowing and difficult imaging of the structures you want to see. But truth be told, it's been a fantastic cannula for us and something that you should try out in your units. So again, it's you know, the right parasternal region is really the go-to spot for this linear probe. I put this picture in just to sort of give you an idea. I don't think of this as like an ECMO scan or an echo scan. I think of this really as a line check, you know, and When I do that, especially with this large footprint, I'm sort of orienting myself from ECMO cannula coming in on the right side of the neck to IVC. That's the orientation that this should run. Unfortunately, in a lot of, in CDH and anatomical, sort of diseases, we can get wild alterations in where the IVC is, wild alterations in where the right atrium is. So this doesn't always apply, but for our medical ECMO runs, this is a really fantastic schema to have in your mind. So it's really a line check is all it is, and an orientation from ECMO cannula insertion to IVC. So it ends up being a little bit sort of like 11 o'clock, if you will, with the probe marker pointed up towards the head. And this is what it looks like with the long linear probe. So it'll take a moment of just adjustment because we've gone from echo imaging now where by convention the probe marker is on the right side. We did a little bit of a flip image when we looked at the bicaval view in the subcostal region. This is like a vascular access, sort of orientation. So we have the probe marker here on the left oriented to the head. So now the venous cannula, the venous ECMO cannula, is coming in from the left side of the screen through the SVC and going into the right atrium. And the IVC is going to be on the right side of the screen. And you're going to see that as a consistent sort of orientation when we use this probe. So to orient you through, again, I sort of told you we weren't going to label things. We're going to walk through them together because unfortunately our machines don't label. And we're going to sort of talk through the anatomy here. So this is the ECMO cannula, the bright, sort of train tracks, if you will, coming in. We actually see a cross section here of the aorta and the aortic outflow tract. And so we don't see the SVC in good cross section here. And you can see that by just the loss of the ECMO cannula on the left side. And then this big chamber here is the right atrium and maybe the tricuspid valve up here a little bit you're starting to see. And already we have great value here in this scan. This is the IVC down here coming into the right atrium. And so this ECMO cannula really is anteriorly oriented away from the IVC. It's really abutting the myocardial wall here in the inferior portion of the right atrium. This is an ECMO cannula that in real time I would say is a little deep. You may be experiencing cutting out issues with ectopy and arrhythmia, those sorts of things. IVC, RA, cannula, tricuspid valve, and you see I didn't label the SVC there. We didn't have a good shot of it. This is a linear probe evaluation of the arterial cannula now in VA ECMO. So here, same orientation, head on the left, feet on the right. We see a little bit of the RA down here, but we're high up on the chest wall here in the suprasternal region near the great vessels. And this is the aortic trunk, so the aortic valve here coming into the ascending aorta. This is the ECMO cannula here coming out through the common carotid and into the ascending aorta. Ascending aorta. I should point out the RV, the most anterior structure, the most anterior chamber on all imaging. The aortic root, cannula there. We get a nice image through the thymus here, and luckily this isn't, lung-filled region that has obscured the cannula shot here. So, I will tell you again, one more time, this can be much harder to image than the venous cannula, and and truthfully, I think we get the most value out of the venous cannula and the inflow port of VA ECMO, but it can be very helpful to see, deep placement of the arterial cannula. This is a fascinating shot done by Dr. Fraga, I love this image. So linear probe orientation, head on the left, feet on the right. You see this long, large ECMO cannula coming in from SVC into RA. Right away, we can tell that the ECMO cannula, the venous ECMO cannula here, is deep. It's abutting sort of the myocardial wall here, the inferior portion of the right atrium. Then we have another cannula here hanging out. This actually is the UVC. So there's a UVC coming in through the ductus venosus and the IVC, and it's deep into the right atrium, and has gotten on top of the ECMO cannula. You see the tricuspid valve here into the right ventricle. This is the aorta here, And so I think actually in these images, Dr. Fraga adjusted the UVC in real time, trying to pull that back from the right atrium and get that into better position. So we see a little bit of an adjustment right here at the end, trying to pull that UVC back. And then same patient. This is a great shot of the, sort of RV here, RA. This is aorta here, and then this is the, arterial cannula coming in. Here's another shot. Let's see. There we go. Another shot of similar orientation. You can see liver here. This is likely diaphragm separating the liver. This is right atrium here. You can really see a deep venous cannula here all the way up against the wall. We really don't see a great shot of the tricuspid valve here, but this again is a situation where I would say this is a deep ECMO cannula. In these cannulas in particular, you need to know where your cannulas are supposed to terminate. But in these cannulas in particular, they're supposed to terminate in the right atrium, freely in the right atrium. And this is really a cannula that's, inflow port is really abutting the myocardial wall. So this is actually real-time adjustment of that cannula. So you can see it sort of starts out deep, and then, with surgeon assistance, or even sometimes all it takes is a sort of a neck roll to move these position in more superiorly oriented position. And you can see the cannula really comes off that myocardial wall into the right atrium. A few cases here, and then we'll have a little time for discussion. So this is not an ultrasound. This is an X-ray. We don't like these, but this one gives a little bit of value. So this is a venous arterial ECMO cannulation, and the tip of the venous cannula really here is down beyond the diaphragm, really down towards the IVC, and so right away you sort of have a hunch that this is going to be a deep venous cannula. Let's see. So an ultrasound assessment. This is now phased array probe. So head on the right, feet on the left. Again, so we're going to reorient ourselves. The venous cannula is going to, we don't have great sort of cardiac structures, but the venous cannula is going to come in from the SVC, go through the, sorry, let me get the pointer back. Come in from the SVC, go through the right atrium, and you really see this cannula is already well through the right atrium, and this is probably in the IVC now. So this is an extremely deep cannula. And you remember Tom actually mentioned there's some venous cannulas where that's the intent, is to get all the way through the right atrium and sort of sit in the IVC. This one is not that way. So this one needs to be adjusted. So again, a similar shot. This is the same image with a linear probe now. So now the cannula is coming in from the left side, the head oriented to the left, SVC, all the way through the right atrium and all well down into the IVC. This may be actually going up into sort of a hepatic vein or the ductus, and a very deep cannula. That one needs to be adjusted. This is a really great case. I think, Tom, this is one of your cases. Just a phenomenal case of well, let me show it to you first. So this is phased array probe, head on the right, feet on the left. This is the right peristernal region. The SVC coming in, you've got the ECMO cannula coming into the right atrium, IVC down here. You actually see the umbilical venous catheter here coming in. And this is a case of pericardial tamponade and pericardial effusion. So you see the effusion up here, you really see the dysfunctional right ventricle here, poor movement of the tricuspid valve. Clearly this is an infant who needed to be on probably VA ECMO. But again, the complication of ECMO cannulation really is pericardial tamponade and pericardial effusion. So something to keep an eye out for. And then same image with a linear probe side by side. So now head is on the left, feet are on the right. cannulas coming in from the SVC into the RA. This is a cannula that's deep, sort of oriented towards the IVC, and then you really can see this effusion. RA is down here, tricuspid valve, RV here, effusion, and really a tamponade physiology on ultrasound. It's a good thing this patient's on ECMO. All right, two-phased array probes. Oops. Oh, this is a deep arterial cannula. So I had to remember what this image was. So this is almost like a peristernal long axis, where for those who are, sort of familiar with the basic views of echocardiography, so left atrium, left ventricle, left ventricular outflow tract, and the aorta, and then you really have the arterial cannula deep down here towards the aortic valve almost, and then right ventricle anterior. And then on this right image, similar picture. This is now higher up in the arch, so this is an arch view, and you really see sort of in sort of progressive scan here, the aortic cannulas coming quite deep down towards the base of the aortic root. Sort of anticipate that this is a common question. How do you work with surgeons in real time? Surgeons are, and this is, I'm not a surgeon, this is what I've seen, and we'll certainly have time for some questions, but surgeons are interested in efficiency, sterility, and seeing it for themselves. That's been my experience at the bedside with surgeons. And so really the, sort of solution to that are these three things. So, to begin to develop some degree of efficiency with these scans, you really need to practice. During cannulation, during an ECMO cannulation, is not the time to practice these views unless you have just the most generous and kind surgeon in the world. It's really getting to the bedside of an ECMO run on a daily basis and doing routine scans, really practicing these scans over and over. And then as the stakes get higher, as the stress increases, you're able to do this with more efficiency. The sterility piece, the answer for that has been this subxiphoid or subcostal view for us. It gets us out of the way of the surgeon's field, down into the abdomen of the baby. And while it might not be the most beautiful picture compared to some of these linear probe pictures, it really gives us the information we need in real time, far better than X-ray does, and keeps us out of the field. And then the final thing I'll say is always orient your ultrasound so the surgeon can see it. Seeing is believing when it comes to vascular access, lines, ECMO cannulas. I mean, it's one thing to see these on X-ray. It's another to really see them in real time. The small, changes in position of the head and the small changes that the surgeon's making and just what that is doing to the cannula. And, it can result in a great degree of buy-in. So those three pieces. And then, again, this is just sort of stressing that third view with the surgeons in particular. You guys might know this album cover. It's one of my favorite albums of all time. This is the Nirvana Baby. There's a long story around this album cover. I sort of picture this as like this is the surgeon's view of an ECMO cannulation. So I flipped it upside down. And again, just to sort of highlight what these different views do to their field. So the suprasternal view, absolutely, an impossible view to do with an ECMO cannulation in real time. Right peristernal view, maybe a little bit more possible, but you're under a drape, you're really starting to reach up into their field. And then the final piece is the subcostal view that's well out of their field. And so this is really that bicable subcostal view is really sort of, where the money is when it comes to working with surgeons at the bedside. And then I want to sort of show you that view one more time. This is during an ECMO cannulation. This is just a couple months back on a medical ECMO infant with the great Dr. Pawlowski at the bedside doing the ECMO cannulation. We have a little bit of buy-in from Dr. Lahaye as well because of his familial relationships, in the unit to our POCUS leaders. So Dr. Lahaye is working with me here, and this is just a really nice shot of the venous cannula coming into the RA in that subcostal view. Pardon me. So venous cannula coming into the RA. This is the IVC down here. Again, this is a strangely oriented view because the probe marker is pointed down towards the patient's left foot. So IVC down towards the probe marker, SVC on the left side of the screen. And then what happens here, this is really fun to see in real time. So when you put color Doppler over this veno-venous ECMO cannula, you can really see this high velocity outflow jet oriented from the venous, from the outflow limb of the veno-venous cannula oriented towards the tricuspid valve. And then you see this blue jet moving away from the probe, coming back into the venous inflow port. And just a really fantastic physiology at play here. Really satisfying to see in real time as the patient goes on, ECMO during a cannulation, and really a fantastic image to share with our surgery colleagues. So take-home points, and then we'll get into a little bit of discussion. It's an important adjunctive imaging modality for ECMO. We still do a lot of X-rays on these infants as we monitor their lungs, but I think it's by and away just the better imaging modality ultrasound is for ECMO cannula position. It's achievable. It's like scanning a PIC, but it's giant. It's an enormous PIC. So it takes a little bit of practice at the bedside, but it'll be one of those things where you'll be quite pleased with just how achievable this skill is. And it can improve patient care dramatically at the bedside with, what sort of Tom mentioned in terms of rates of complications, rates of malposition, what we've seen in our unit. Please feel free to reach out to us. I know this, isn't necessarily the best format to discuss and talk ultrasound, and I hope this was helpful, certainly, and giving you a little bit of foundation to go into your units and try these things on your next ECMO run. But we're always open to feedback you might have or questions you might have by email, and or happy to set up a time to talk over a virtual meeting. With that, I will unshare my screen and invite the incredible panel we have here in the moderator's deck.
Thank you so much to our presenters for sharing their expertise and perspectives. We will now transition to the Q&A panel. We have Dr. Linden and Dr. Gowda joining our guest speakers today as Q&A panelists. Dr. Allison Linden is a pediatric surgeon at Children's Healthcare of Atlanta and then assistant professor at Emory University. She has done additional fellowships in pediatric surgical critical care and ECMO. She's the surgical director to the NICU, PICU, and ECMO programs and the program director for the ECMO fellowship. Dr. Sharda Gowda is a neonatologist at Texas Children's Hospital and then associate professor at Baylor College of Medicine. She specializes in neonatal ethics and has expertise in pulmonary hypertension, congenital diaphragmatic hernia, ECMO, congenital heart disease, and pediatric cardiac critical care. While waiting to get the questions from our audience, I would like to start by asking, when first starting this process, what strategies have you used to gain support and buy-in from surgery and cardiology teams?
I'd be happy to take that. Thanks, Dr. Kitab. So I definitely learned a lot of this while I was still a trainee. And so I wasn't necessarily the person kind of developing this process. I was learning from Dr. Fraga, who I think we all know. But I thought what was really important was what Will was talking about was just the frequency of scans, getting very comfortable with it, doing it on scans and off times when the patient is stable, and actually doing scans on the most complicated kids. So like your CH kids where you don't have a standard anatomy, and it's going to challenge your understanding of where to do it. And when you build your skill base and feel more comfortable, then you're going to feel more comfortable talking with your colleagues and talking with and having like a skill set and communication with them and showing what you're able to do. And when you present that benefit to them and say, hey, I can do this at the bedside and I've built up the skills, I feel comfortable doing this during cannulation or to augment your routine surveillance imaging, then you can show your worth then, right? And so then you can get additional buy-in because people need to believe you and they need to see what you're doing. And it is more about your actions and words in these situations. And especially we've gotten questions about how do your cardiology colleagues feel about this? Are we stealing studies from them? Are we, is there like a turf war or anything? If anything, I feel like our cardiology colleagues appreciate it because then we don't get the frantic fellow at 3 a.m. for cannulation who this is the first time they're seeing a CDH or something like that. And so we have an expertise in this patient population that a lot of our young cardiology trainees who frequently are doing the echoes at least overnight in our institution don't. So we can help each other. And I think that's a big piece. It's like helping each other. And we're not trying to answer a question that's not specifically about the cannula.
I'm happy to jump in and kind of speak to that question from a surgeon's perspective. I find it immensely valuable to have that real-time image guidance when we're placing cannulas, when we're moving cannulas, daily. And I think Will really brought up quick, down and dirty advice about what we think of from the surgery side. And I honestly think you're going to have surgeons who are much more familiar with looking at cardiac images, and some surgeons won't be familiar at all. So the more you engage them and explain what you're seeing, the quicker this will kind of take hold as a more just routine daily imaging modality.
Thanks, Ellie. I actually have a follow-up question to that. How do we convince the surgeons to say, hey, it's not just the positioning or rope, putting a roll under the shoulder when the cannula are too deep? How do we convince them?
Yeah, so I think a way to kind of almost like prevent that discussion is that during initial placement, I strongly advocate for taking the roll out while you're getting that initial point of care or real-time echo. So the way that we tend to do it at Emory and Choa is we will get the real-time echo with the drape still on. So everything is still sterile. And at that point in time, I would advocate removing the roll from the bed or from under the shoulders so that you can get your first image with the cannula tip right where you want it, knowing that it's probably going to need some repositioning. But I think you have to start there rather than starting with a roll under the head, because so much of that will change as babies get edematous, as hemodynamics change, physiology changes, depending on why they're on ECMO.
Thank you so much. We have a question from the chat asking, in addition to the probes mentioned in the presentation, is it possible to do this with a convex probe?
I would say absolutely. I mean, we've in other targeted imaging and central line evaluations, we've actually found that a lot of what we can do with the long linear probes, we can do with convex linear probes and the curvilinear linear probes or curvilinear probes. And so it's worth trying. Absolutely. We haven't done it a lot just because those two probes have become the staples for us, but I can't imagine why you couldn't or shouldn't be able to do it with the curvilinear probe.
Yeah, I may be able to add a little bit more to that. For sure you can. I think it is just like everything else in medicine, the most comfortable you are with a specific probe and you're able to identify the structures like you're looking for and the orientation of the heart that you kind of need to, like Will was mentioning about how, okay, now I'm closer to the LSVC, I mean, left side or to the pulmonary artery or the aorta, where am I? And do I need to move to the center medially or do I need to move laterally? Those are the things that you need to be very cognizant of. As the probe is the tool, but you are the main kind of the creator of that image. And so you can alter that the way you want to see it. So definitely possible.
Thank you. Another question from the chat. I'm guessing that the utility of scanning arterial cannula for positioning is for surveillance imaging. Is there much experience with arterial cannula placement by surgeons under POCUS guidance or directions?
I'm happy to kind of jump in with my perspective. As was mentioned, the optimal view for that cannula tends to be kind of right in the middle of the sterile field. And the way to get around that, honestly, is just put a sterile probe cover on the ultrasound probe and have, whoever is doing the study put on a gown, get sterile with the surgeons, and then you can very easily use that image to help with cannula placement. Because in all honesty, putting those cannulas where they need to be right from the start is crucial. And so I think, that bedside imaging person getting sterile with the surgeons is a great way to overcome that.
Thank you. Another question, how do you approach training at your institution? Are there any simulation tools that are helpful so novice learners are not learning on ECMO patients? And how do you decide which providers to train for this indication?
That's a great question, and it'd be interesting to hear different perspectives from the different institutions because I think it varies between center for sure. So we, in our institution, just generally teach all the fellows, and then as they kind of stay on and grow and kind of join faculty, we have kind of like inherited ultrasound faculty within our unit. At the same time, we've also, other attendings have been interested in learning it, so we've also taught other attendings as well too. And so that kind of encompasses who we overall teach. And we don't necessarily have, for anybody who's training who doesn't feel comfortable, we have an ultrasound group that is willing to review any images that are obtained in real time and kind of give feedback and kind of give the blessing of what they're seeing. And it's grown large enough that at least we can see it in real time. But I would say that in terms of a specific credentialing standpoint, we, as an institution, have developed a specific number of scans that you have to do to then meet credentialing and meet competency for these images. So I would encourage that your group kind of thinks about that and thinks about how many studies you need to perform to then kind of reach that competency. If you don't want to reach to learn on ECMO patients themselves, I think a great tool is to learn your basic cardiac physiology and cardiac views, because a lot of these, I know Will was talking about, these are like very much like line checks. And a lot of these images and these probe positionings are based off of some standard cardiac views. So that is like a nice foundation. You really need to know cardiac anatomy. You need to know what to expect in each of these kind of standard views to then build on it and then alter, like to just tweak the probe positioning a little bit to ultimately see the cannula position and really understand what you're looking at. You'll need to know cardiac anatomy and what it looks like ultrasound to really know what you're looking at and have it make sense.
Thank you so much for sharing.
And
go ahead.
Thanks, Tom. That's actually really awesome. So trying to look at healthy babies, even in the newborn nursery, just trying to talk to the parents and getting the orientation right. It can take a little bit of time, but it is a great way to train. As we all know, the 10,000 hour rule does apply, especially when you're making critical decisions. And I'm going to put a shameless plug here for the POCUS collab and the lab that Alan Groves has, and he has all the, there's really all the simulators and things like that that you can borrow. You can just rent for a couple of weeks or months and then go learn, 8 hours a day, because that's something that you can't do on real babies. So things like that truly make people quite efficient and proficient and competent in doing these ultrasounds as well.
Thank you. We'll take one last question as we're over time. So what roadblocks have you encountered and how did you overcome them?
Yeah, I'm happy. That's a great question and encountered by everybody. It's also certainly one of the more difficult ones as we all experience challenges as we move forward. So the biggest roadblocks, I feel like, are your own comfort and convincing other people that you know what you're talking about. And so that comes with practice and ability and understanding of what you're doing. We are, I'm happy to hear other people's experience as well too. I was fortunate to kind of walk into a system that had encountered the roadblocks prior to me, I think, in terms of establishing relationships with radiology, establishing relationships with cardiology, and that had taken many, I think, years and a lot of coordination and trust that built between partnerships. Because, right, this isn't just about neonatology. This isn't just about surgery. This is about really collegiality with radiology, cardiology, neonatology, and a collaboration between them all, because we all have different areas of expertise that we can approach this imaging problem by. And so I think when you think about roadblocks, you think about a lot of different program building questions. So not just training and education, but also image acquisition and storage with quality assessment and control and all those different things that are running in the background that you need to feel comfortable with. And I think are a little bit out of the scope of this talk specifically. But we have a lot of resources with and other presentations about program building as well too.
Thank you. All right, so thank you to all our speakers and panelists for this wonderful discussion. And thank you all for joining us today. This webinar has been recorded and will be uploaded to the Collaborative's website, www.neopocuscollab.com. If you are interested in receiving communication about the future educational opportunities offered through the Collaborative, then please subscribe with your email at the website. We hope to see you all at our next webinar. Bye.
Thanks so much for the invitation.
Thank you.